Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. If you are hearing this right now, then you are not currently a Journal Feed subscriber and so will not be receiving the full Journal Feed podcast, only getting a portion of the past week's articles. Don't worry, if you would like to get access fully to both the podcast and the blog, then you'll just have to become a member. All the details for that are at journalfeed.org. And remember, we never want money to be a barrier to better patient care. So if you're having any trouble affording a subscription, just get in touch. We'll help you out. This is the audio version of the past week summaries, which this week were brought to you by our authors, Bo Stubblefield, Megan Hilbert, Samuel Rouleau, Jacob Athels, and Clay Smith. And so we get straight into the first article, which was titled Factors in Initial Anticoagulation Choice in Hospitalized Patients with Pulmonary Embolism, out of the JAMA Network Open. Okay, so your patient has a PE, you're going to want to anticoagulate them. You thin their blood, hopefully the PE kind of goes away slowly. That is assuming that they don't have a massive PE, meaning that we need to get rid of it right away. Now, if you're anticoagulating someone, you actually have a fair number of options into how exactly you're going to anticoagulate them. You could give them warfarin if you so choose. You could give them a DOAC. You could give them low molecular weight heparin or unfractionated heparin. Now, the kind of older practice was to give unfractionated heparin to quite a few people. This way, the thought was that you could quickly anticoagulate them, and then if you needed to shut off that anticoagulation, then you could do that quickly as well. However, recent data really shows that, first of all, you're not anticoagulating quickly. Indeed, at 24 hours, a minority of people are properly anticoagulated. And there's also, so not only are they not being fully anticoagulated a lot of the time, they also have a higher risk of bleeding. So you're really getting the worst of both worlds here. That's with the use of unfractionated heparin. As a result of these pitfalls, the recommendations are to give a DOAC or low molecular weight heparin. Despite this, the rates of unfractionated heparin use have actually increased in the United States, while the rest of the world, well, it's been steadily decreasing for them. Why is that? These authors hope to try to identify the factors that are driving us to keep using unfractionated heparin. In order to get to the bottom of this, they interviewed 46 physicians in the United States and did a structured interview to try to figure out why they keep using this drug. Now, the most common reasons seem to be that people are just kind of agnostic about it. They just don't think about what they're doing. They haven't questioned this practice and thus haven't changed it. Another big factor was just what they learned when they were residents and what they've been using this whole time. They've always used unfractionated heparin, so why would they stop now? I think this is very similar to just not questioning what the best choice might be. After that, there's institutional culture, which is that, hey, everybody else is using it, so I'm kind of expected to use it. The nurses are familiar with it. Everybody's just used to doing it, so I do it too. I never thought that was a great reason to really do very many things. Like your mother probably always said, if your friends are going to jump off a bridge, would you do it too? And then lastly, there's therapeutic momentum. These physicians that were interviewed were internal medicine physicians as well as emergency medicine physicians. And so when you start a drug like unfractionated heparin, the hospitalists, well, they kind of feel obliged to just continue with whatever you've started. And then later on, they might switch it before that patient goes home or something like that. So the choices that we make in the emergency department are important for the ongoing care of these patients. Even if the hospitalists kind of quote unquote knew better, they still continued the unfractionated heparin, which is a shame. Where I've had the fortune of practicing, you can only have a heparin drip if you're going to the ICU or you're still in the emergency department. So if you're going to be admitted to the floors, then you're switched pretty quickly off of unfractionated heparin. So that's nice, not a big problem that I have to deal with, but it seems like the rest of the world that's not necessarily the case. All right, and now you know why at least some of your colleagues might be using unfractionated heparin. If you're still using it routinely in patients who have PEs, there are of course situations where it is still appropriate, then why don't you question why you're using it as well? Have a look at the guidelines. They're certainly not recommending it. Okay, in a spoonful, many people still, probably inappropriately, use unfractionated heparin for the treatment of a pulmonary embolism, largely because they just haven't questioned what they're doing. So, question your decisions. And then we skip straight to the 5th article, titled, Does Single-Dose Epinephrine Improve Outcomes for Patients with Out-of-Hospital Cardiac Arrest and Bystander CPR or a Shockable Rhythm? Out of the journal Pre-Hospital Emergency Care. Now, this is kind of just a secondary analysis by the same authors that did the first paper of another paper which looked at when EMS symptoms in North Carolina switched over to a protocol where they only used a single dose of epinephrine for out-of-hospital cardiac arrest. This is kind of interesting, and there's really not a lot of data that looks at the different dosing strategies that we could potentially have for epinephrine in out-of-hospital cardiac arrest, or any cardiac arrest for that matter. There's definitely been some skepticism that perhaps we're using too much epinephrine and that this is causing harm. However, the data is kind of scarce. We've actually covered this in the past, and the last review I saw on it, well, you just can't separate out, did the patient just not be resuscitated for longer and that's why they got less epinephrine? Or were they resuscitated for a really long time and thus, of course, the outcomes are going to be worse? It's really hard to separate those things out. From the first paper that these authors were a part of, well, they showed that pre-hospital single-dose epinephrine, this was associated with similar rates of survival to hospital discharge, but decreased ROSC rates when compared to the traditional multi-dose epinephrine protocols. This paper now is a pre-planned secondary analysis of the same data, looking at whether or not bystander CPR was important or if the patient had a shockable rhythm or not between the two groups, multi-dose epinephrine or single-dose epinephrine. If you ask my personal opinion, I think this could have all probably been done within the same paper, but why not split it up and make your CV a little bit longer? Okay, so what did they find? Now, if the patient received bystander CPR, then there was some benefit to just getting one dose of epinephrine instead of the multi-dose protocol, though this was not statistically significant. Those who did not receive bystander CPR, they actually had lower rates of ROSC with the single dose. So if they did get bystander CPR, great, single dose better. If they didn't, then single dose is worse. Just in terms of the cohort itself, the proportion of shockable rhythms was significantly different between those who got multi-dose epinephrine and those who got single-dose epinephrine. Is this due to the epinephrine or just happens to be part of the data? It's hard to say exactly, but there was no statistical difference in the rates of survival to hospital discharge between the two groups, whether or not they had a shockable or non-shockable rhythm. So either way, it doesn't really seem to matter. Now, unfortunately, the authors did not report how many doses people actually got when they were on the multi-dose protocol. Maybe it wasn't recorded in just which protocol the patient was on, although that might be interesting data. In a spoonful, this is preliminary data that perhaps we don't need to be giving as much epinephrine as we do in an out-of-hospital cardiac arrest, though I wouldn't start changing my protocols just yet. Okay, that's it for this week. Let's do a quick wrap-up of everything we talked about. From the first article, are you still using unfractionated heparin for your PE patients? Perhaps you should be questioning your practice, as many probably should be as well. And from the 5th article, single-dose epinephrine is an interesting idea. It's worth seeing if we can fine-tune our epi strategy in out-of-hospital cardiac arrest to try to squeeze some benefit out of it. Overall, though, I think you're best served by just continuing with your traditional ACLS protocols for now. Again, if you are hearing this right now, then you are not a part of the members feed, and so you missed 3 articles from this past week. What articles did you miss? Well, we did one, which was a meta-analysis on antivirals for influenza in non-severe cases. And then we talked about the latest on H5N1 and how that's doing. And then finally, a review of alcohol use disorder. Links to all the original articles can be found at journalfeed.org, or just follow the links in your show notes. Our goal here is for you to read less, learn more, and save lives, one spoonful at a time. Thank you.